Hello, everyone, and welcome to our webinar, 5 Years Later, the ongoing COVID-19 and long COVID crisis and the future of public health. My name is Ken Todd, and I'm the Director of Communications for the COVID-19 Longhauler Advocacy Project. I have been disabled by long COVID since February 2021. One quick note as we begin: if closed captions would be beneficial to you during today's conversation, you can enable them by clicking on Show Captions at the bottom of your screen. And please forgive me if I stumble over any words. It's one of the impacts of long COVID. As we come together on the 5-year anniversary of the COVID-19 pandemic during Long COVID Awareness Week, we are still dealing with the consequences of repeated infections, chronic illness, and the systemic failures that have left millions without answers, treatments, or protections. COVID-19 continues to spread largely untracked, public health infrastructure is being dismantled, and funding for long COVID research and disability protections is being stripped away. Since 2020, disability rates have increased 35%, with long COVID being a leading driver. Long COVID is estimated to cost the US over $1 trillion annually and continues to devastate lives, the workforce, and the economy. We are here today because the crisis is far from over and requires urgent action for the millions still suffering. Today, we will explore the lessons learned and not learned from the COVID pandemic response, the long-term consequences of long COVID, the weakening of public health protections, and how we move forward in an era of increasing infectious disease threats. We will also discuss solutions, what needs to be done to strengthen surveillance, protect our communities, and rebuild trust in public health. Today, I'm honored to have the privilege of introducing Dr. Michael Osterholm, the Director of the Center for Infectious Disease Research and Policy at the University of Minnesota, and the founder and president of the COVID-19 Longhauler Advocacy Project, Karyn Bishof. Dr. Osterholm has many roles at the University of Minnesota. In addition to being the director of the Center for Infectious Disease Research and Policy, he is also a Regents Professor and McKnight Presidential Endowed Chair in Public Health, Distinguished Teaching Professor in the Division of Environmental Health Sciences in the School of Public Health, a professor in the Technological Leadership Institute in the College of Science and Engineering, and an adjunct professor in the medical school. In November 2020, Dr. Osterholm was appointed to President-elect Joe Biden's 13-member Transition Advisory Board for COVID-19. In 2018 and 2019, he served as a science envoy for health security on behalf of the U.S. Department of State. In addition, Dr. Osterholm is a member of the National Academy of Medicine and the Council of Foreign Relations. In 2005, he was appointed by HHS to the newly established National Science Advisory Board on Biosecurity. In 2008, he was appointed to the World Economic Forum Working Group on Pandemics. From 2001 to early 2005, he served as a special advisor to the then HHS Secretary on issues related to bioterrorism and public health preparedness. Dr. Osterholm served in various roles at the Minnesota Department of Health for 24 years, and the last 15 as state epidemiologist. He has led numerous investigations of outbreaks of international importance, including foodborne diseases, the association of tampons and toxic shock syndrome, and hepatitis B and HIV healthcare screenings. Dr. Osterholm is a global expert on pandemic preparedness and bioterrorism threats. His papers warned of an influenza pandemic before COVID-19 and outlined steps for better preparedness. He has also been a leading voice on the risks of biological weapons targeting civilians. His New York Times bestselling book, Living Terrors, provides a critical review of America's readiness for a bioterrorism attack. Next, Karyn Bishof is a former firefighter paramedic whose career was cut short after becoming disabled by long COVID following a COVID-19 infection in March 2020. Before beginning her career as a firefighter paramedic, Karyn provided home care, spanning from an infant with critical cardiac conditions to elder care for patients with severe dementia. From 2013 to 2018, Karyn worked as a physical education and health teacher, serving as director of athletics while coaching multiple varsity middle school and elementary teams in soccer, basketball, and cross country. A passionate athlete, she played soccer in a women's league and coached her son's teams before COVID-19 left her, like many others, fighting for workers' compensation, Social Security disability, and other support services necessary for survival and care. Karyn holds a Bachelor of Science in Exercise Science and Health Promotion. Determined to advocate for those affected, she founded the COVID-19 Longhauler Advocacy Project in June 2020 from her bed, and later established it as a 501c3 nonprofit in November 2021. She has played a key role in shaping national long COVID policies, serving on the committee at the National Academies of Science, Engineering, and Medicine that developed the official long COVID definition in 2024, now adopted across the US government. She also serves on the NIH Recovery Initiative's Ancillary Studies Oversight Committee and the Treat Long COVID Cardiovascular Agents Working Group. Her advocacy extends to coalition building and contributing to initiatives such as co-founding the Long COVID Alliance, which launched the Infection-Associated Chronic Conditions Initiative. She is a member of the American Public Health Association and the Disability Economic Justice Collaborative. She previously served as an external contributor to the AHRQ Long COVID Care Network and is currently serving as a patient advisor for the Council of Medical Specialty Society's expert panel on long COVID education, engagement, and care management. Karyn remains committed to advancing recognition, research, and policy solutions for the hundreds of millions affected by long COVID and to ensuring that patients' voices are heard and included in the spaces where decisions about long COVID are being made. We are very excited to have you join us today. We're about to begin the conversation. If you have questions for Dr. Osterholm or Karyn during the discussion, please share them with us by using the Q&A function, which is available at the bottom of your screen. Thank you very much, and now I will hand it over to Karyn to begin our conversation.
Thank you so much, Ken, and thank you everyone for being here today with us during Long COVID Awareness Week for this important discussion 5 years later. Dr. Osterholm, it is great to see you again. Welcome. Let's dive right in. You have dedicated your career to infectious disease research, public health, advising nearly every presidential administration on pandemic preparedness and response. Your expertise has shaped national and global policies on bioterrorism, emergent infectious diseases, and most recently, COVID-19. Now, as we navigate the long-term consequences of this pandemic, including long COVID and ongoing threats from new and re-emerging pathogens, you continue to play a critical role in advancing research and informing public health strategies. Given your extensive experience navigating both scientific and policy changes, what initially drew you to this field? And as you contribute to ongoing research efforts, what areas are you currently focused on? And why does infectious disease preparedness remain one of the most pressing public health challenges of our time?
Well, first of all, Karyn, thank you very, very much for having me. Ken, thanks for that kind introduction. It's a great honor to be with both of you. For those that don't know, Karyn and I have developed a special friendship per our previous experience working on this together, and I can't tell you what an honor it is to be here. And most of all, I want to acknowledge all those who are listening today who have been impacted directly or indirectly by the whole issue of long COVID. And for those who have lost loved ones, my sympathy and heart goes out to you. To those who are suffering every day, I want you to know today your voice is being heard, that you are recognized, you are seen for what you are going through, and how we must continue to work to eliminate long COVID and all the assorted conditions that really relate to a similar kind of pathology. So, Karyn, to answer your question, I could probably take a long time to say that it took an entire village to raise me to get me to where I'm at today. But I'll start out by the fact that I was born and raised in a small Iowa farm town, and my father was a photographer at the local newspaper office. And it turned out that the owners of the newspaper, a husband and wife team, were truly experienced journalists, and in particular, the woman who literally became kind of the mother of my soul in my later years, was, I think, the only person in all of Northeast Iowa subscribed to the New Yorker magazine. And she would get her issues in the mail. And at the time, there was a series of stories written in the New Yorker by a gentleman named Burton Rouget. They were called Annals of Medicine. And they were kind of whodunit stories. They were wonderful Sherlock Holmes-like outbreak stories, and often detailing an outbreak that the Center for Disease Control had worked on at that time called the Communicable Disease Center. And I fell in love with these stories. And so every time that Nana, her family name, finished her New Yorker, she'd call up and I'd run 6 blocks up to her house to get that New Yorker issue. And I would sit there and read it and knew I wanted to become a medical detective. And just to short circuit all of this a bit to kind of frame it, it was many years later, as I was a state epidemiologist at the Minnesota Department of Health, in which we had a major outbreak in southwestern Minnesota associated with eating hamburger containing thyroid gland in it, causing people to develop what we call thyroid toxicosis, which was a serious issue. A number of people died from having too much thyroxine, a type of chemical that regulates your metabolism. And the reason I tell you this story is because it was the last story Burton Rouget wrote before he died. And I had the good fortune to actually come full circle with my mentor of at a distance, the man who motivated me. So I've known ever since I was in 7th grade, I wanted to be a medical detective. And I'm so fortunate to have had that opportunity to do that. So in terms of the focus areas today, I think there really are 3 areas that I'd like to really cover. And one of them will be research and development roadmaps. You know, the idea that we really do have a very important need yet to develop vaccines that are durable and broadly protective against coronaviruses, against influenza viruses, etc. And we need manufacturing and supply chains ready for the next pandemic. Today, we are less prepared for the next pandemic than I believe we were in 2020. Part of that pails back to the issue of the trust in public health. And as we've discussed on numerous occasions, the kind of messaging that occurred during the pandemic often led people to not trust public health. And we have a lot of work to do in that area to better understand how to relate to the public, how to understand what we need to hear, and at the same time, understand what we can share and how that can be helpful. Let me give you an example also of just our lack of preparedness, so it doesn't sound like it's just rhetoric. In a very recent study that confirmed a previous study of 8 years before, both with the same results, showed that globally right now, we have the ability to make about 4 billion doses of influenza vaccine in 1 year, meaning that, in fact, with the 2-dose regimen required, that's only 2 billion people that would actually have access to this vaccine in the first year of a pandemic. Well, I think my math last time I checked, 2 billion is a lot less than 8 billion, which is the world population. Now imagine that we don't have any more capacity than that. Then we said, well, you know, this is a vaccine made with inbred chicken and eggs. You know, it's a complicated vaccine development that hasn't changed much since the 1950s. Let's look at newer technologies. And we look at the mRNA technology, which we'll get into, I know, later today, also just talking about how effective those vaccines are. And finally, after several years of back and forth, we got the administration, the Biden administration, to invest about $500 million in translating mRNA technology to influenza. And that contract, which was let last year, was just clawed back by the Trump administration this past week. So now we don't have any more research going on. And the one thing that mRNA technology brought us, while it did not necessarily make for a better vaccine than the one we had already, it surely is one that we could ramp up much more quickly and get to the world. So, you know, just look at things like that and you'll realize that we're really hurting in that regard. The third focus, or the second focus area, I think, is the issue of antimicrobial resistance. People just do not have a full sense of what this means. Many of us on this screen had grandparents and great-grandparents that grew up in a world where we didn't have antibiotics, the pre-antibiotic era, where literally a simple scrape on the knee, an ear infection, could cause you to actually develop a life-threatening infection. And with the advent of antibiotics, we fundamentally changed our world in fighting the microbes against these infections. But as we know, microbes, which multiply as frequently as every 20 minutes, every time they do that, they have one more shot at the genetic roulette table to develop a mutation, a change in the bacteria that now could render it so it's not susceptible to that antibiotic. Those are what we call antibiotic resistant strains of the bacteria. We see that with viruses. We see that with even parasites. So the challenge we have today is how do we make these new antibiotics that we need and not overuse the ones we have already that would lead to more resistance? Well, the new ones are a real challenge because most of these antibiotics are gone. We've used them up in a sense. It's like using up our oil. It's like using up our water supplies and groundwater. And unfortunately, there aren't a lot of new ones coming down the pike, in part because they're just difficult. Second of all, because of the fact that who wants to invest in a drug today where we tell you, don't take it unless you absolutely need to, and then take it as little as you can, okay? Imagine a company that sells a drug that you have to take every day for the rest of your life, and one that has a much higher profit motive. So we have a real disadvantage here. And it's very sobering to know that there was a report issued by the UK government in 2017 that still really holds true for today, that basically estimated that by 2050, this antimicrobial resistance will actually be a greater cause of death than cancer and diabetes combined. We're going back to a post-antibiotic era, i.e. pre-antibiotic era world. And so this is a challenge that we have a lot of work to do. Vaccines could be very helpful if we could find vaccines to actually prevent from getting these antibiotic-resistant infections, how we use antibiotics today to help save them. And let me just give you an example of an unwise use. Already, we're hearing from this administration that the issue with H5N1 in chickens is causing a lot of problems. Why? Because people can't get their eggs. Well, as one of the measures suggested to do to address this is to, in fact, start vaccinating chickens and turkeys, and also using therapeutics in treating them, and particularly in providing their water supply to prevent them from getting infected, or at least reducing the seriousness of their infection. Well, this may help out in terms of getting us more live chickens that may produce more eggs, but we need to remember our recent past. In 2005, when H1N1 started circulating in China in poultry, the Chinese reacted by putting the amantadine antivirals in the water supply of the poultry in China. And within a year, resistance was so widespread, the drugs became ineffective for global use. We no longer use them because there's so much resistance. Today, we have the neuraminidase inhibitor drugs that we use, oseltamivir, baloxavir, etc. That is the only last line drug we have for influenza. And they're now proposing to start treating these poultry in the United States with these drugs. If we do that, I am convinced that within a very short period of time, we'll see a global resistance challenge with this flu virus and that last line drug. So we still have a lot of work to do in antimicrobial resistance, and this is one we all need to speak up on. A short-term gain of a few extra eggs versus losing a human therapeutic agent, I don't think there's much of a debate, or shouldn't be, about that issue. The final piece I would just cover today is the high priority to me is the zoonotic spillover preparedness, i.e. what does it mean in terms of animals with the spillover of their viruses and bacteria to human? We all know that one way or another, the influenza and coronaviruses originate in aquatic birds, waterfowl, and then through genetic changes, eventually make it to being able to infect humans. And then when the additional changes in that virus, they then can cause an infection in humans where they now transmit it to other humans, i.e. often the beginning of a pandemic. Now, this is an important issue from the standpoint that literally just several weeks ago, the Chinese reported on the finding of a new coronavirus that was much more akin to the MERS coronavirus that we saw in 2012 and 2015, that fortunately was not nearly as infectious as it was SARS-CoV-2, but it killed 35% of the people it infected. And now imagine if you had a highly infectious coronavirus like SARS-CoV-2, tied into a 35% case fatality rate, not a 1% case fatality rate. Imagine the impact that would have. And so we really have to be mindful of this and know that, you know, the late Josh Lederberg, Nobel Prize laureate, once said, the bugs were here before we were here, they're here while we're here, and they're going to be here long after we're gone. And we need to continue to remember that. So let me just conclude this answer by saying, many people, I think, believe we should be done with infectious diseases. You know, when I got into this business in 1975, I have to tell you, I had a lot of people say, why are you going into the horse and buggy age? You know, infectious diseases are dead and gone. Look at today, the problems have never been more immense. The global distribution of so many different infectious agents transmitted by mosquitoes, transmitted by animal populations that suddenly spread quickly around the world with our international trade and travel. All of these issues today add up to the fact that we're not done with infectious diseases. And I would just conclude this by saying we often focus on infectious diseases in the acute infection, and that's obviously very important. And then we have those diseases that are chronic infections, much as we see with tuberculosis or viral hepatitis, etc. But we all know here today, there's a third type of infection, which in fact is an eliciting event somewhere with an infectious agent, and it causes a lot of changes in our bodies from an immunologic standpoint, the i.e. long COVID picture, which can be as devastating as having actively growing virus or bacteria in your body. It can be every bit as devastating, if not more. And so today we'll also really dig into that issue of what that third category I call the sequelae of an infectious disease that in some cases is as bad, if not worse, than the original infectious disease itself. So I hope that gives you an overall sense of where I'm at and where I'm coming from. And again, I just have to say, Karyn, what an honor it is to be on the same screen with you. So thank you.
Awesome. Thank you for that detailed answer and kind of the overview. In what you just mentioned, you know, early on, many leaders pushed for herd immunity or really pushed, you know, the sole reliance on vaccinations to solve the pandemic, which led to poor policy decisions, you know, a rollback of protections like masking. Public health caved to political and economic pressures, fueling mass infection and reinfections, each increasing the risk of long COVID. Today, at least 62 million US adults and 6 million children have long COVID, with over 15 million of those adults having severe impairment. It's driving workforce shortages, economic instability, and costing the US at least 1 trillion annually. Now in 2025, the average number of COVID-19 cases remains higher than in the first years of the pandemic. As a result, we're seeing consequences like immune suppression, leading to reduced ability to fight off other infections. This year alone, we've seen significant increases in flu, pneumonia, RSV, and even fungal infections, suggesting a broader public health crisis emerging from ongoing COVID-19 exposure. Similar to what we saw with HIV/AIDS, there are growing concerns about immune dysfunction, increasing susceptibility to other infections, compounding long-term health risks. So looking back at 2019, at the very start of the pandemic, and looking at COVID and long COVID in 2025, how has your view of this virus and the long-term sequela of a COVID-19 infection changed for you?
Well, first of all, let me just say that I myself had almost 6 months of what were considered a type of long COVID symptoms, severe fatigue, brain fog, etc. And this occurred in 2023. So while I surely have not experienced what many of you on this webinar have experienced, I had a taste of it. And I got to tell you, it was hard. It was really hard. And just to give you an idea, here's somebody who was knee deep into COVID, working on it, developed my infection in 2023. And while I only had moderate illness, I noticed about 2 weeks later that I was asked for what I'd like to drink at an event. And I knew what it was, but I couldn't remember the name. Well, suddenly over the course of days, I had more and more situations like that where I couldn't remember. And I was feeling very fatigued. And I should have immediately thought, oh my God, this is related to my COVID infection. And so what did I do? I said, oh no, my God, I'm getting Alzheimer's. I'm getting Alzheimer's, early Alzheimer's. I'm getting it, okay? that's how far removed I was from rationality, because if I had just thought through it, I would have thought, well, what was the inciting event here? It was COVID. And so I just want to say that I surely don't pretend to have anywhere near the challenges that any of you had, but it gave me enough to help educate me as to just how critical this could be. Well, in terms of what happened, I have to say that yesterday was actually an anniversary for me in a sense. It was the 5-year anniversary of the WHO declaring the pandemic. Let me just say that by itself brought back some rather challenging memories, because it was on March 10th, 5 years ago, that I was on the Joe Rogan podcast. And in the next day, there was 10.5 million downloads of that podcast. I learned about communication in a whole new way. But what was also telling is on that podcast, I had indicated that there would be upwards of 800,000 deaths potentially in the next 18 months. And at that point, you would have thought that I had the most dreaded disease in the world, spreading it to everyone, because no one wanted to be near me. They all thought that I was exaggerating, scaring people needlessly, that was a challenge. Well, in fact, 18 months later, we hit 800,000 deaths in this country. And the reason I bring up this story is not to say, oh, boy, I was so smart. I'm not, but it was clear that we were not ready to accept the fact that a pandemic could happen. There was such denial early on, not just in the public or in political leaders, but even in our own colleagues, that were aware that this was happening, but they thought, no, this would most will be like a bad hurricane. It'll blow through in a couple of days, and then we go immediately into a recovery. They didn't see what this was going to look like over the months ahead. And I think that was a challenge. One of the other issues is we didn't know a lot about how a coronavirus would circulate this. It was noted that, and I served as a special assistant to Tommy Thompson at HHS right after 9/11, and I was quite involved with the U.S. response to SARS in 2003. And then in 2012, I actually served as an advisor to the royal family of the United Arab Emirates when MERS first broke out on the Arabian Peninsula. And then in 2015, when we had a large MERS outbreak at a hospital in Seoul, Korea, Samsung Medical Center, related to someone who had been in the Middle East and came back with MERS. And I was in Seoul working on that. So I'd had this experience with coronaviruses. And my first thought was, when the first awareness of this happened, and our team at CIDRAP picked up on this actually in December of 2019. And we were already working on it well before the 1st of January. And at the time, it appeared that this was influenza. And I thought, oh, no, here's the pandemic. Then we realized, no, it wasn't influenza. It was a coronavirus. And I thought, oh, this is great news. Okay, we're going to have some bad illnesses here, but we're going to control this, because SARS and MERS, as bad as they weren't that infectious. Okay, so we could control it. Well, that was short-lived, because then within about 10 days, we had enough evidence from our contacts in Wuhan and from Hong Kong, elsewhere. There was a lot of transmission occurring from mildly ill or asymptomatic people that was causing very serious illness in a lot of other people. And so actually on January 20th, our center posted a statement on our website saying, this is now going to cause a pandemic, get on with it, get ready. But again, there was such denial for that to happen. And so this was a real challenge early on, is what would this look like over time? And we put out a document in the spring saying, we don't know if herd immunity will occur or not, because based on what we knew with other coronaviruses, immunity tended to be lagging in duration, much like we see with flu, where you may get a few good months of protection, but then it starts to wane. And if that's the case, herd immunity was never going to actually ever exist. Would the virus continue to change? We didn't know. But I think that suffice it to say, what we could have and should have done more of was just be honest and humble up front and say, this is what we know, this is what we don't know. With what we know, this is how we know it, so you can trust it. What we don't know, this is what we're doing to try to find out. And I mean, I'll just give you one last example of where I think that played out, was the issue with vaccines. And we just talked about this briefly. But the fact of the matter is that in that November, December time period of 2020, it was a remarkable time, given the mRNA technology studies were coming forward, both The Pfizer and Moderna studies were published in the New England Journal of Medicine with 93+% protection. Everyone was euphoric, saying, this is it. Well, I remember very well sitting there saying, well, wait a minute now. Remember, we have these other coronaviruses and they don't seem to have very durable protection. What's this one going to look like for this vaccine? And it turned out that we said, no, just get vaccinated, take your mask off, we're going to be home free. Well, as you know, that wasn't the case. Protection lasted for 4 to 6 months, and then you started to see it really drop. And if we had just said to people in November and December, when that vaccine first came out, this is what it's worth for 2 months worth of data. Okay, it's looking pretty darn good, but we don't know what it's going to do the 3rd month or the 5th month or the 8th month. But we're going to keep tracking it and find out. And we're going to tell you, and we may need a booster one day. Think how the public might have responded differently if we had shared that message, as opposed to the fact that, don't worry, it's all taken care of. So I think there were a lot of mistakes made and things like that, but we should be learning from those for the future. Now, in terms of what we got right, the number of public health people and the number of healthcare workers who did so much during this time period, we have to acknowledge these very, very important people often even ended up, in a sense, sacrificing their life just so that people could be cared for. And so today I would say, we all owe a great debt of gratitude to these individuals for what they did. I think as we move forward, we have to learn how to conceptualize COVID now among the other respiratory illnesses, but we also have to recognize the long COVID picture is very real. And no one can be considered expert in COVID unless you can really understand also what it means to be responsible for caring for long COVID and what that means. And that is a huge, huge issue. The last thing I want to say is that, I've been quoted a few times as saying this, you can call it COVID a seasonal disease if you realize it occurs in every season. Okay, that's it. There's no evidence yet of seasonality with this, even though some people say so. And we have to recognize that. And we also have to recognize that our healthcare system today is not in any shape to take on a pandemic like COVID again and actually effectively handle it. And God knows what it would be like if it was a more severe pandemic. And we're not addressing our healthcare challenges right now, and we surely need to be.
Yeah, I mean, the pandemic was mishandled, as were past pandemics, and I think our failure to follow the sequela from things like HIV, AIDS, and post polio, and 1918 flu and things like that have left us at a disadvantage for where we are today.
Can I just add a piece to that real quick? That's a very important point you make. Thank you. I'm glad you emphasized that. I just want to say that one of my greatest frustrations about the response was actually, in a sense, after the fact. And for those who are young enough, quote unquote, and old enough to remember 9/11, there was a wonderfully comprehensive evaluation done of the 9/11 event and a follow-up in which was bipartisan, no fingers pointed, nobody ascribed, what they did wrong. But there was a very comprehensive, detailed report that went through the lessons that should have been learned for the future. And many of those lessons were addressed in terms of what was needed for future protection. We did not do that for COVID. We haven't done that for COVID. And we need to have a hot wash, a summary report, much like 9/11, detailing that, of which long COVID would be a very important part of it. How did it get missed? How did we, when we finally did get recognized, how did we respond? What could we do to respond in a more effective way, short term, intermediate term, and long term? And so I think your point's a really important one. And all I can say is that I hope it's not too late. I have a book coming out later this summer that is really an attempt to address what a 9/11-like commission should have addressed, trying to cover these very issues and making certain that people remember that this is what happened, this is what we can do differently so it doesn't happen again.
I think that kind of leads perfectly into my next question, which is talking about with the administration mishandling of public health and weakening the public health system, and now with another Trump administration in place, we're seeing even deeper rollbacks, jeopardizing healthcare access, disability protections, and critical research needed to address the ongoing crisis of long COVID. We've seen the termination of the Secretary's Advisory Committee on Long COVID, removal of long COVID resources from government websites, removal of patient contributors to the Long COVID Care Network, disbandment of CMS Health Equity Advisory Committee, the gutting of DEI programs, NIH funding cuts that threaten the Cures Act, which provides billions in NIH funding for disease research, streamlined FDA approvals, expanded patient access to medical records, increased support for mental health and substance abuse treatment, and advanced precision medicine for personalized care, and more that's coming down the pipeline. Seeing the progress and programs built by patients from the ground up over the last 5 years, dismantled overnight in most cases, has been more than gut-wrenching. It is lives that are being affected every single day. Public health protections and disability rights being systematically dismantled through funding cuts and policy reversals further weaken our ability to address long COVID and other ongoing health crises. So what do we do now to protect public health, including acting independently of the federal government?
Well, first of all, let me be really clear about one thing, and that is I have served in every presidential administration from Ronald Reagan up to the Biden administration, as you pointed out earlier with Ken, that I actually served as a science envoy for the Trump 1 administration in the State Department. I've always just been a private in the public health army. That's my job. Whoever's there, I'm there to help serve and do the best I can for whoever they are. So take my comments in that light, please, okay? I'm not partisan, haven't been partisan, but I also have I may say maybe a reputation for not always sugarcoating things. We are right now in a state of utter public health destruction. It is beyond anything that I could have imagined. And yet, in a podcast that I do, I actually talked about last November what might happen, and unfortunately, it's all happening. Number one is taking us out of the membership picture with WHO is a real challenge, a huge challenge. And that is because of the fact that we are part of a global system of infectious diseases. A germ somewhere in the world today could be everywhere in the world tomorrow. So it's very important that we are part of that picture, and we're not anymore. And our lack of funding for WHO, 18% of the budget came from our membership, means that that's going to compromise that agency. So that's number one. Number two, here in the United States, as you've already pointed out, it was more than painful for me to watch what happened with USAID over the course of the last 4 weeks. The U.S. Agency for National Development has been one of the most important international public health diplomacy, soft power activities in the world. Under USAID, which basically accounted for less than 1% of our government's budget, was an incredible outreach to the world to help, particularly with infectious diseases. Most notably is PEPFAR. I was very involved with the early days of HIV/AIDS in this country. And in the mid to late 80s, before we had the antiretroviral drugs, really we hit a peak in the number of deaths that were occurring. And Karyn, there were weeks where I would attend 5 funerals a week. And I thought, I can't imagine this. I can't have this happen again. And then along came the antiretroviral drugs, thousands of dollars treat one patient a year. But over time, that all changed. And we got the drugs down to hundreds of dollars for treatment for extended periods of time. And President Bush, Bush 2, initiated PEPFAR, which was an amazing program administered by USAID that provided antiretroviral drugs for those living in low and middle income countries, 22 million worth. Those individuals received their drugs through distribution systems, particularly various groups. The moms on the motorcycles was one of the most important ones, where they would go from village to village entrepreneurially providing these drugs, making sure everybody took them every day, we basically nailed HIV away. And even though we had infected people, they were living quality lives, health was outstanding. And even more dramatically, we eliminated a whole generation of HIV infected children because the mothers were treated at the time of birth to make sure that it didn't transmit to the child. That's all gone now. I think about the 5 funeral a day world coming back in a couple of years that I just can't believe will happen. We're going to see it with tuberculosis. We're going to see it with malaria. There are any number of diseases worldwide that we have been so important in helping to reduce the risk of by USAID. Polio. USAID has played a critical role in polio response in places like Pakistan, Afghanistan. That's gone now. Maternal and child health clinics, safe water for families, infection treatment of diarrheal diseases for young children, one of the number one causes of death in young children in these countries. That's all gone. Someday history is going to look back at us and say, how could you let that happen? And for such a cheap price. We're not talking about, you know, spending billions and billions and billions of dollars that might otherwise go elsewhere. So I think this is really the challenge we have today, is what's also happened in this country. We have the Secretary of Health and Human Services, who largely is an anti-vaccine secretary. We are already seeing, for example, vaccine hesitancy issues have been addressed through a series of funded projects to understand why are people hesitant. They were all pulled this past week. You can no longer do those, and no new ones will be funded. I could go through the laundry list of what's happening. Look at the outbreak of measles we see happening right now in Texas and New Mexico. You know, it's a huge challenge. So I think we have to recognize we're up against reality right now, but this is not a time to quit. This you can't, you know. And for me, I said, even though I'm an old man, I said, you know, in one of my podcasts last fall, after the election, I'm in here for sure for the next 4 years. And why? Because I've got kids and grandkids. And you know what? Well, who am I if I can't help with that? So I think all the things you laid out, you did so eloquently. Thank you. You're right about all those things. And just know that unfortunately, they're part of an entire network today of efforts that have been canceled, efforts that have been demonized almost. When you hear about how some of the USAID workers were treated. This week, we're going to find out how many people take the buyout at HHS. They offered it to 80,000 HHS employees. This is FDA, CMS, CDC. What's going to happen? NIH, what's going to happen? We don't know. So I have to acknowledge to all of our dear friends and colleagues on this Zoom today who are suffering from long COVID, the infrastructure is not going to get much better. It's just not. And we have to make do with what we have, but that doesn't mean you sit down and shut up. You don't. You stand up and you keep going forward with this. And if there was ever a time for leading the cause like you've done, Karyn, it's now.
We are doing our best to continue fighting. It's been a very difficult field to navigate from the very beginning, and we face even greater barriers now coming up that we really need the community to rally around, especially with the massive loss of trust in public health, which was largely eroded during the pandemic due to the inconsistent messaging, political interference, the policies, everything was, economic and political interests were chosen over public safety. And that's still the case right now, even as we look at potential future pandemics that are, right at the edge right now. How do we begin to rebuild confidence in science and public health guidance, especially with everything going on? Public health leaders play a huge role in regaining trust, and there's people like you who will speak up and do the right thing. How do we encourage other people to do that who have the platforms, to do so? And what strategies can we better implement to really have better engagement with communities and reach these decision makers to not abandon public health?
Well, I have to be honest and say I don't have a good answer for you. because this is really an unprecedented situation where we're at right now. I will say that number one is that it's going to get a lot worse before it gets better. And what I mean by that, take for example, state and local health departments, which have in many ways been on the front line tirelessly trying to deal with issues with limited resources and limited access to the real experts. Right now, if you look across the board in the United States, the vast majority of infectious disease work done at state and local health departments is federally funded. Minnesota is a good example, a crown jewel health department that has distinguished itself over the years for its incredible activities. 5% of their budget is state money, 95% is federal money. That federal money is going to be cut in many, many ways over the course of the upcoming weeks. We are going to see, I fear, state and local public health departments becoming mere shadows of what they once were. And at a time when we actually need to invest more, not less. And so this is going to be a real challenge. And I don't have any other ways to say it, but you can't give up right now, because it's not just for each of us, but it's also for those who are yet to come. And so I would say at this point, we're working at our center to identify ways that we can help address the shortcomings of what's starting to happen, because CDC has now been pulled out of the mix. They can hardly talk to any of us. We need that kind of work done. So at this point, we're going to continue to work on that and try to move that forward. And all I can say is that, failure is not an option here. It's not. This is more, you've already been in the place of trying to swim up Niagara Falls. You've been doing that for a few years, okay? So others are going to be confronted for the first time. Oh my God, what's this all about? We need to help each other. How do you get through this? How if after all these years of lack of response, what do we do now? And I think that this is where the activism of groups like yours and individuals such as yourself are going to be important to help instruct others. Hang on, don't give up. These are the things. Concentrate on a couple of really important issues. Which studies are important. The group at the VA hospital in St. Louis, incredible work that they're doing there right now, working on this issue. Help support those groups that you can. And, demand to the best we can that even at NIH and places like that, what can they do to be helpful? Now, I have I have to say a qualification on that is because they're going to be going through the same problems we are. They're going to see massive cuts in employees, challenging in economic environments. And so we just have to continue to get through this. And that I wish I had better ideas, better thoughts. We're sure thinking about them. But at this point, we just have to acknowledge we're in a world of hurt.
Yeah, I mean, patient communities, including those of us living with long COVID, have been at the forefront of advocacy, demanding research, funding, pushing for policy changes, and fighting for recognition when institutions have failed. From the earliest days of the pandemic, organizations like the COVID-19 Longhauler Advocacy Project have led critical initiatives ensuring that long COVID is recognized as a serious public health crisis, securing patient representation, in the places needed to ensure that patient voices and experience are represented and to protect those that are affected. But despite these efforts and accomplishments, many have now kind of been rolled back by this administration. These setbacks are, making it now more important than ever that institutions and researchers and policymakers proactively involve long COVID patients in their work, not just for optics, but as a core part of the decision-making process from the beginning of projects through implementation. Previously, some agencies were required to include patients' perspectives in their initiatives, but with those mandates disappearing, it's now up to individual organizations to ensure that long COVID patients remain central to shaping solutions that will directly impact our lives. So how can public health leaders build stronger partnerships with patient communities and ensure our expertise is valued in research, policy, and clinical care development and what steps should be taken to formalize patient involvement so that we're not just consulted, but actively driving the future of long COVID. And this is an answer more directed towards your colleagues in the medical and research field that should be working with the patient community.
Right. Well, I think, first of all, I think we should all take responsibility for this, because the we is meaning not just them, it's we. It's our families, it's our colleagues, it's our friends. And so we should all have a concern about that. Let me just say that for me, this has even much more meaning, because way back when it was not popular, I worked on and published several papers on what at the time was called chronic fatigue syndrome, and saw the devastation that had caused, okay? And the number of years people suffered with that. Well, now, of course, we've come to understand the entire complex of immune modulated disease issues. And so we've had a need for a long time, whether it's chronic Lyme disease or, chronic whatever, to have addressed this issue. Now is the time where we have enough knowledge to say, yes, it is a real issue, and yes, we must address it. I think the challenge is going to be funding for a whole lot of things right now is going to dry up, if not be almost totally non-existent. This is where we need to get creative. I would offer the following suggestion, and I know that you've all worked and looked at this, but the business community has to understand, from a standpoint of employees, this has taken a heavy toll on them. And how do they help support, any answers or any kind of studies to fund it? Philanthropic organizations that have not traditionally been involved with this kind of work, what can they now do? Because it has such impact on society, it has such impact on the workplace. We need to find new and creative ways to support this. I think there are physicians and researchers in our midst who do want to do this kind of work. They are very keen at doing it. They just need the opportunity to be there and to be able to have the funding to do it. So I think continuing to push on this as a, not just doing it out of the goodness of your heart, which, for me, is watching people suffering from long COVID. I've emotionally have a heart tug, but let's just get real cold. Let's talk about cash. If you want to have a business today, who's your employer going to be? What are they going to be like? Are they going to be reliable? This is why we need to address this issue. And you can't argue with that. You can argue about, well, a lot of people suffer, or it's very expensive. This is a cost benefit issue where you can say, I don't have the numbers in front of me, but for every dollar you invest in this, look what you may get back in return in terms of a healthy workforce. And so I think that's going to be a key piece. I'm not hopeful at this point that you're going to see a lot of support coming out of this administration and this Congress for this kind of work, but it shouldn't mean that it can't be done and funded. And I think a coalition of businesses, a coalition of philanthropic support really can help drive it, particularly for researchers out there who I think are fully prepared to work in a more unconventional funding source, because this is just so important.
Yeah, I mean, as from my perspective as a patient, at the start of pandemic, I was a firefighter paramedic and never imagined COVID-19 would reach my community so soon, let alone impact me personally. From the day that it was declared a pandemic, 3 days later, I had COVID-19 and I was never better since. At the time, my case was considered mild to moderate. And just, to emphasize, there's many people in the long COVID community that have mild to moderate cases. I think there's a lot of misconception out there that you have to have a severe case of COVID, or you have to be hospitalized, or you have to have pre-existing conditions, or it doesn't impact kids, it only impacts the elderly. And there's so many misconceptions that have led to infections and reinfections and unfortunately death and disability of millions of people. And I'm now in a place where I never expected to be 5 years later. My health is not getting better, it's getting worse. My long COVID has led to the development of POTS and lupus, gastroparesis, chronic migraine, cognitive impairment, mast activation, cyclic vomiting, and more. Yet this is not just my story. This is millions of people who have a collection of so many things going on that it's nearly impossible to really find care. I mean, 5 years later, I'm still spending hours vomiting every morning. I don't sleep. I live in constant excruciating pain. Lately, I've been having severe vision issues that lead to intermittent blindness for days at a time. The fatigue that you mentioned earlier is beyond anything I've ever imagined. I compare it to kind of those last few moments before anesthesia knocks you out.
Wow.
You're like me and you're fighting it, trying to see how long you can go, except it never ends. That level of fatigue is relentless. Being unable to even just sit up, let alone stand up for long periods of time, experiencing dizziness, nausea, heart palpitations, weakness, syncope, brain fog, all of these things impact the basic activities of daily living. And people are losing their jobs due to long COVID, or caregiving responsibilities. They're being forced, into unsafe workplaces or out of work because those workplaces are unsafe. They're draining their life savings just to survive. And then you have the parents of children with long COVID who are facing penalties when their kids can't attend school. And schools continue to remain a major source of transmission for all things, not just COVID-19. We're waiting months to years to get medical care. For example, pre-pandemic, there were 54 board certified autonomic specialists for 3 million people with autonomic dysfunction. That number is at least expected to be 3 times higher. And there's still 54 autonomic specialists, which were not enough to deal with the 3 million people before.
Yeah.
So, we have public health leaders continuing to downplay reinfection and risks while patient protections are systematically stripped away, when we're in need of more clinicians in these fields and more education for people to, help treat us. And I don't find that finding care now is any different than it was in the beginning of the pandemic. There's still no approved treatments. There's no cures. And doctors just don't know what to do with us. We're ping pong from doctor to doctor, given this drug to treat this symptom and sent on our way with a best of luck. Hopefully research finds the answers, which is why it's so important that these programs are not rolled back right now. And, the truth is, it's not just about us, it's about everyone. Public health is an everyone issue. And many who once thought that chronic illness and disability wouldn't affect them now get it. But public health has to be proactive, not reactive. And we need real-time surveillance, honest public health messaging, and transparency. People deserve to know the risks of infection and reinfection and what this virus can really do. And if public health agencies were honest, it would change the game. So we exist really to try and fill these gaps and make sure that as patients, we're representing our stories, and that, it's not been weeks, it's not been months. We are 5 years down the road for many of us, and progressively getting worse and losing more of what was helping us get better, or at least being on the road to helping us find solutions.
Yeah, and thank you for sharing that. I know that's very difficult, and it's difficult from the standpoint of what you're experiencing and just the frustration on top of what you're experiencing with your actual illness. I think if I could say that my sense is, and this is where I think we have to go kind of what I call root cause analysis, to look back on what can public health do or should do. And I know many, many public health employees, people professionally who have given their life to caring, want to do the right thing. They don't have oftentimes the tools, they don't have the information. And I think if there's one thing that, you and I have talked about in the past, is just how important it is to educate the healthcare providers, the public health teams out there as to what's happening. And that's why, I've so appreciated even just my time with you and talking to you. You've helped educate me and even more about it. And so one of the things that before they can help, we need to have a much more educated public health and medical care workforce to understand what's going on. I think you're absolutely right. I mean, I heard that many times when I was dealing with chronic fatigue syndrome early on was, well, this is all psychological, it's not real. And just to cut through that was dramatic and it was tough. And so today it's even tougher as we find our healthcare system challenged. We find, access to care more and more limited. It's one thing to get in to see a physician who might have an expertise in this. Heck, it's a problem today just getting to see your family practice doc. And so we have a healthcare system that also is not responsive. That's why we need you. That's why we need this organization, okay? Because to me, it is the one advocacy group that can continue to push forward the margins, the boundaries, and don't give up. And anybody who just heard you speak knows you don't give up. They know that you're committed and that you're there. And, and you are fortunate to be with a group of individuals of like minds and like perseverance. But it doesn't make it any easier, I know. But just know that you are making a difference. You're going to be heard more. And it's a challenging time period to be in this business. But this is far, far too important to just let it go. And as you and I have just talked about, COVID's not gone yet. We're still seeing new COVID cases. Fortunately, it's at a much lower level than we'd seen in the early days of the pandemic, but we're still seeing new long COVID patients diagnosed or at least occurring every day.
Yeah, we're currently seeing over 3 million COVID cases a day, and if you do the math and break down the prevalence of long COVID, we're going to see continuing cases and increases with reinfections and even co-infections that can trigger all of this. So I know a lot of our audience wants to know, given where we stand today, what should we expect in the coming months of years? How can we prepare ourselves and our families, our businesses, our schools? And there's a lot of questions that I'm starting to see in the chat about updates on H5N1. So if you want to answer kind of that together and what we should be prepared for.
Well, first of all, you can't give up. Okay, you can't give up. Is far, far, far too important. No matter what happens with public health, no matter what happens with medicine, you can't give up. And I think that you and the organization itself is a very critical source of activist information. I watched what gay men did in the mid-1980s with the studies done by NIH, the drugs issue. And all I can say is they were the lifesavers because they forced a system to have to deal with HIV in a very different way than it ever had before. I think in some ways you're dealing with a very similar phenomena in a way of you are forcing the system to not only hear you and see you, but understand you and to realize by incorporating this energy and this challenge into the work as opposed to keeping it out is actually going to be benefiting everybody. Okay. Talking to you, you learn so much. And so I think at this point, that's to me, don't give up. I'm not giving up. You're going to hear about several initiatives coming out of our center very shortly. They're going to be major efforts just to respond to the lack of communication, the issues around vaccines, and what they can do and can't do, all coming out of our center to take on what's happening right now. So we all just need to stand up and do that. To me, that's really the important piece. In terms of H5N1, well, I've been studying influenza literally almost all my career and was very involved with the early days of H5N1 emergence in Southeast Asia. Actually, I was in Thailand, Indonesia, Vietnam, and did work on those. And that virus basically, at the time, as you know, killed about half the people that got infected with it, but fortunately, it was very limited transmission. I just remind everybody, if they don't know this, or just to keep the idea of what's happening here, all influenza viruses originate from waterfowl, avian species. They've been infected with influenza viruses dating back to antiquity. What happens is there's actually a set of these viruses that are largely avian viruses, meaning that they have certain receptor sites for cells in birds, not in humans as such. And so those are the ones that we see circulating a lot in the bird population and have only rarely been involved with humans. Well, now that's changed. H5N1 is still a largely avian virus, but it can occasionally infect humans And of course, it's at this point, it can also still be a severe viral infection. What we don't know is what is its potential to become a pandemic virus, meaning that it readily transmits to humans, by humans, and from humans. And at that point, that would be the likelihood of having an influenza pandemic. What we know right now is that the virus took some major changes about 2.5 years ago and developed into a new clade, a certain type of H5N1 that was much, much more transmissible across mammal species. That's why we see so many different animal species now infected with this and dying. It surely also transmitted between birds, but specifically, the bird population that has been of note has been the poultry. And the fact that these wild aquatic birds, waterfowl, when they're sitting in fields, etc., nearby operations, have basically transmitted the virus onto these poultry inside the barn, largely through either contamination from people walking in the fields where the virus was, or the wind-driven virus in there. And so that's not new. We've seen that with poultry literally dating back to 2015, but large outbreaks in that. What is new is a little over a year ago, we saw infections develop in dairy cattle for the first time. Now, interesting enough, dairy cattle actually have receptor sites for both the bird virus and the human virus influenza strains in their udders. And so this is where we get concerned. Just as we talk about pigs all the time, pigs have receptor sites in their lungs for both bird viruses and human viruses. And if you get a co-infection, they may actually merge together and do a thing called reassortment, which gives you a brand new virus. That's what happened in 2009 with H1N1. We saw in pigs in central Mexico a reassortment event occur, and we had a new virus, H1N1, that caused a pandemic then. So at this point with the cattle, we haven't seen that happen yet, but we worry. Now today we have cases throughout the United States, continue to see cases in California dairy cattle, and they largely recover from this virus infection. Some do not, but most do, unlike the birds, where once this virus gets into a chicken house, virtually all of them will be dead within a few days. That's how lethal this is. So the bottom line message is here is we don't know if H5N1 is going to cause the next pandemic or not. It could, but it might not. It could be another influenza virus that pops up. Remember, H5N1's been around now since 1996, and we haven't seen a pandemic yet. Could happen. We just don't know.
Yeah, I think that, public health and surveillance really has to step up. And I think a lot of participation in surveillance has a lot to do with public participation in testing. But there are issues with access to testing, such as cost and their general availability. We can't afford to keep making the same mistakes. Mitigation measures like masking in healthcare settings, improving indoor air quality, and clear public risk communication should not be controversial. They should be common sense. Yet, instead of strengthening public health initiatives, leaders have chosen to ignore or dismantle them, leaving millions at risk and our workforce increasingly disabled. Long COVID is not just a healthcare issue, it's a workforce issue, an education issue, an economic issue, and a disability issue. We are disabling the country in real time, and without urgent action to prevent further infections and reinfections, and expand clinical care and support for those already affected, we will be dealing with the consequences of this for generations.
I think if I could just add one thing here, though, I think that it's important to distinguish public health, clinical medicine, and healthcare financing. They're all separate entities that all have something to do with what you're just saying, and which I agree with. My experience with public health is that these are people who are very, very well intended, people who want to do the right thing, often lacking the resources to be able to really do it. I mean, for example, surveillance. Surveillance is a very important part, as you've illustrated, but it's also not cheap. And, to be able to get it done, where you have paying for the laboratory testing, you're paying for the information. And that has made it difficult often for public health to actually to do that. And what we saw during the pandemic was the fact that we had a very broken surveillance system in this country. It was 50 different states, often local and city county health departments, some who use fax machines to move information. That's how much they have in way of modern equipment. And so what we really need right now is to basically have a grand plan for how would you set up the system for surveillance. Today with electronic medical record, we should be able to do a lot more. And that's why I mentioned earlier about the work at the VA in St. Louis, because there the researchers are using the kind of electronic medical record follow-up, et cetera, that can be really enhancing and getting work done. So I think that's really important to, again, push this forward. I think the public health people today at the state and local level, at least, want to do more. And that's been my experience. They comment to me, we just don't have the resources. And I fear that in the next few months, we're going to see, even, as I said earlier, even bigger and bigger cuts in public health. They're going to really challenge us to do the work that needs to be done.
Yeah, as we mentioned earlier, we met at the, American Public Health Association annual meeting last year. And while we were there, we exhibited. We brought a team of 7 to 8 volunteers to make sure that we were getting information out to public health professionals and departments of health who we wouldn't normally connect with. And we had one of the busiest booths. And I would say that the majority of people who came up to our booth thought that they had long COVID, had a loved one with long COVID, and we're really utilizing the resources and saying, just like you said, we want to do something, but we don't have the support either from their administration or the budgeting and things like that. So a lot of what we've been pushing the long COVID community do is trying to hit the state level, talk to your governor, talk to your state senators and lawmakers, and get them to allocate long COVID funding to your state's budget. And also in this setting, getting state funded allocated to long COVID research kind of in some ways helps nestle it from being pulled back as federal funds or canceled. With kind of, go ahead.
Can I just add a point there? I think, first of all, I want to compliment you on the booth. It was I was there. I saw how busy it was. It was really great to get that kind of information out. Again, I come back to the point that I made earlier. I think, Willie Sutton was once asked, why do you rob banks? That's where the money is, okay? He said. And I think that right now, given the challenges, by God, there are more challenges, there are disasters happening on the public financing side of public health and where we're going. This is where I keep coming back to the private sector, the business world. This workforce issue is real. There are a lot of really highly competent, capable individuals who are not working today because of long COVID. And so what we need to do is also not just invite, but convince the private sector why they want to get involved with this, because they're losing potentially a very valuable resource in their workforce. And so I won't get discouraged. Well, I should say less discouraged if in fact we can't get federal and state funding. I mean, I look at Minnesota, we're a state here that has been notably done well over the years. We have a $6 billion deficit facing us in the next biennium. Now you go and try to ask for a lot of new money in a $6 billion deficit on top of what's happening at the federal level. But companies still need help. And so I think this is where the philanthropic world and the private sector, if we could get them together, helping to organize them to say, this is a win-win. Okay, if you invest in this work and invest in what we're trying to do, we win because it's all about how to improve the quality of life for someone with long COVID. They win because they get these incredible employees. So I think I'm always looking for the can do, will do attitude, how we're going to do this. Don't tell me we can or not. Tell me how we're going to do it. That's what I want to know.
I agree full-heartedly, and I think that working together is really the path forward, and we need to keep pushing forward with the bi-directional communication and partnerships and cross-sector work to really move things forward. With that, I'm going to hand it back to Ken to take us into the Q&A session from our audience.
Thank you very much for this. Thank you. It's great to be with you.
Stay with us. We have the Q&A.
I'm coming. I'm here. I'm here.
Well, we've gotten lots of responses, lots of questions. We have a very engaged audience. So We're unfortunately not going to be able to get to all of them, but let's get rolling right now for questions. The first one is for Dr. Osterholm. Many long COVID patients report being dismissed or misdiagnosed by doctors. What needs to change in medical education and clinician training to ensure that long COVID and post-viral conditions are properly recognized and treated?
Well, let me just start off by saying I think the mind-body connection has long been a challenge for the medical community, okay? And it goes back to any number of different topic areas where, mental illness and perceived mental illness and physical illness were often confused, which was which and how and why. I think we just need a lot more education about why there is a biologic basis for a long COVID condition to occur. It's not in somebody's head. Well, it could be the brain fog, but it's not because it's in their head. It's because they have a immunologic dysfunction that we're getting more and more data on to show that that's the case. And so I think once they begin to understand that, then they say, oh, well, this maybe is something I can treat or something that I can respond to. And, well, this is where we need the basic research to help provide the information that then what I consider Karyn and you and the group and others like you can get out to the world and say, look, this is a real illness. This is how you can diagnose it. These are the criteria. We actually have objective criteria. It's not just guess. In the old days of chronic fatigue syndrome, well, I'm tired. It was a constellation of just, okay, you have it. They didn't really, there wasn't any measures of any kind of testing and so forth that would tell you that. I think today we need to make a concerted effort, and that public health should be part of this. And remember, this is not just about COVID. Sometimes I think people somehow think this got invented with COVID. COVID is critical. COVID is absolutely a critical part. It's the largest part today of this. But we've been seeing these kind of conditions for decades. I mean, I saw them in my mid-70s and early 80s research. And what we have to let people understand is that only now have we come to the realization of just how extensive these are and what kind of conditions can be associated with them. I'm tired, fatigued. Well, I'm tired too. No, this is a different kind. You have to understand, this is not just being tired. And I think that kind of education will come with time once we have more objective data on what's happening. And I see that data starting to get generated, looking at, measures that once a physician has that kind of information and they can do something about it, I think you'll see a very different picture than we have now.
Kind of as a follow-on, someone had talked about how they're getting treated both with like traditional medicine and functional medicine, and there's a lot of research being done on the traditional medicine side. What is your point of view on functional medicine and research involved there?
Well, again, I'll take any kind of research if it's scientifically sound and well done. Okay, I don't come in with a preconceived notion saying this can or can't. Okay. And I think that that's really a very important point right now. A lot of functional research that I have seen hasn't stood up to the rigors of scientific testing in a way that would validate that it's real. The results are real. And so I think that's what we just need. Everything should be applied to a certain standard where study design, how you measured things, what you did, basically provided that objective kind of evaluation. And to me, that's really important. But I surely would never write off anything that it would be considered functional research if in fact it's a well-designed study. And I would say the same thing about traditional medicine. Okay, I don't want to just see a case series of something that kind of is an anecdotal kind of picture. We need more objective data, which I know we can get with this, that would help then say, okay, this takes us to this point. This is where the action's happening. This is where what's being modulated in our body is happening. And then you know where you can act upon it. And that to me is really important.
What are some of the most promising treatments and therapies for long COVID that you've seen? Do you see?
Well, I'd actually say Karyn's probably better at that than I am right now. I haven't kept up on that as much. But I think what's important is how much of it is actually based on actual physiologic findings or research that shows what's happening. And immunologically, I think that's, we have a number of different drugs that can be helpful in certain immune modulating conditions, but I don't have today. I wouldn't want to tell anybody what to get without knowing more about that. I know, Karyn, if you have some thoughts on that.
Yeah, so, we can't give medical advice, but really the most, common driving mechanisms in long COVID are thought to be viral persistence and immune dysfunction and dysregulation. And I think really our path forward is antivirals in two senses. One, something that more strongly affects acute infections than some of the things that we have available right now, and more access to some of those, but also antivirals for some of us that are years out, that if viral persistence is a key that we can use for treatment. However, I think we need a combination therapy. I don't think that there is one therapy for long COVID.
Yeah.
And I would say that immunomodulators are going to be a huge player in treating long COVID and figuring out how to prevent long COVID. And I think that a combination of antivirals and immunomodulators, both in the early stages and for people with long COVID, are the path forward. Who's going to pick that up and kind of lead some of those studies and clinical trials is kind of up in the air. We need people who are going to step up and run those, but those people also need the funding to do so. So right now our push is really to try and find and locate that funding and make sure it's getting to the right people who are going down the right paths to try and find long COVID. We're beyond the stages of collecting symptoms and all of that kind of stuff. We really need treatments, cures, and prevention.
And if I could just add one piece to this, because this is where it gets very complicated, and I don't want to make it sound like this is easy, as I tell people, long COVID is not rocket science. It's much more complicated. Okay. Having spent so much of my career working on Lyme disease and chronic Lyme disease pictures, one of the things that I was struck by was this idea that it is an ongoing proliferation of Borrelia burgdorferi in your body. And there have been a whole series of double-blind placebo-controlled trials using various antibiotic approaches, of which every one of them failed to show any benefit from antibiotic therapy. Now, it doesn't mean that there still isn't an infection there. It's just that the antibiotics didn't get rid of that infection, or that, in fact, there wasn't an infection there, but it was part of this ongoing immunologic dysfunction. And so I think this is where we need the systematic studies. I agree with Karyn about the issue of infection, for example. How do we determine if, in fact, this is a sequestered infection going on that basically is causing this to happen? And what are the criteria for defining that? When is it that if you're 2 years out and you're still picking up, basic antigen from coronavirus, that's a big deal, okay? Then that tells you something must be still ongoing there. It should be shutting that many months later. This is, I think, where we need a lot more of the research on also than is to check off the things it's not. I think we often focus on this is what it is, and we may not know right away what it is. But if I can eliminate these 10 things and say it's not these, then it allows us to focus more on this and this. And it's in some ways really focusing down to get to those potentially several major sources of what's happening here. And then we can isolate that. That's I think is important to find out what doesn't work and what it isn't, as much as it is to say what works and what it is.
Okay, we have a couple questions on public perception. How do you recommend communicating to the public about health concerns like long COVID in a current environment of skepticism? And what are the biggest barriers you all are facing when advocating to both the media and policymakers about long COVID?
I think you want credible voices out there. People who have been cases. I think, Karyn, you make an incredible voice. Your impact you had on the audience at the American Public Health Association meeting was dramatic. I think you want to find medical care providers who have studied this enough to be able to say with some certainty, this is what we know and don't know. And you want them to be talking heads. And you want them to talk not just to the conventional public audience, they need to talk to their colleagues. They need to talk to the insurers. They need to talk to that entire a range of people who have some kind of interface with the healthcare system. And that's where education becomes really important. No, it tells people, no, this is not what this is. This long COVID has this, this, and this. This is what we can show you objectively, etc. And I think that that's going to be important, is to have really effective, strong spokespeople. And if you look today in many of the chronic diseases we have, or cancer-related diseases, having a strong spokesperson for that particular disease has often had great dividends and payback in terms of people believing in it, supporting it. And I think that's what we really need today.
Regarding public health, are you seeing states interested in collaborating amongst themselves as possibly an alternative to national coordination and as a way to spread expertise? And
yeah, a really good question. I wish I had a better answer in the fact that right now states, I think, are looking to try to how to survive. And COVID is acute disease. COVID is a long-term condition. It has to fit into a portfolio of 100 other infectious diseases that they're all trying to deal with. Right now, the big concern has been H5N1 and how it can do it for surveillance. And as we just discussed, there's some real challenges within surveillance for that. Then you keep drawing out these different diseases, and pretty soon you've got an entire portfolio of all these diseases for which you have no support for. So I can't see that right now long COVID takes a high priority. It could. It's a disease of some real consequence. And that's why you just have to keep advocating. Don't ever get tired of advocating. The squeaky wheel is what eventually gets oiled. And it shouldn't have to be that difficult. It should be based on what the impact of this disease is. Therefore, how does it rate in importance? And I think that's the thing. The other thing that I worry about conditions like this is that far too often, there's an old saying in public health, if you ain't dying, it ain't critical. Okay. Well, you're not how many people are dying from long COVID versus a lot of other acute issues, but it is important. It's disability. It's about quality of life. And we shouldn't put that up to say, well, how many people died from long COVID? That's an absolutely inappropriate overview of what you need to do to address this issue.
We had a question about AI. AI is turning up everywhere, right?
Yeah.
How can we as a community harness these AI-driven innovations to enhance our health and address challenges of long COVID?
Well, let me just say right now, I'm learning a lot about AI. Okay, so you have to understand, I'm an old timer here. I thought the idea of a portable phone years ago was, who needed that? Okay, so I've come a long ways, and it helps to have kids and grandkids. When I have a technology problem, I just call my 12-year-old grandson and get answers. It is going to provide us with the ability to really search the world for any information on COVID and bring it together, rather than have it be just a chance getting together. With AI, we now can really scan what's going on out there in a way that then can help conclude meaningful information that can more quickly take us to the next level. What could be done potentially in months now probably takes us years and years. And AI is going to speed that up a lot.
All right, I think I will wrap the questions. Karyn.
Thank you.
Thank you, Dr. Osterholm.
Thank you. And I hope, and I'm thinking of you, and good luck with that fatigue. Okay.
Thank you.
Yeah. And by the way, the drink, it was red wine. Okay. So just, if you forget.
So we covered a lot today, and it's clear that there are immense challenges facing public health right now. People are uncertain, concerned, and looking for leadership in a time when trust in institutions is at an all-time low. At a moment when we need strong, transparent, and relentless advocates for public health, we are definitely grateful to have you in this fight and in our corner. But public health isn't just a responsibility of epidemiologists or doctors or government agencies, it's all of us. It's the choices that we make every day, the way we protect one another, and how we hold leaders accountable for safeguarding our collective future. With that in mind, do you have any final thoughts that you would like to leave our audience with?
Don't give up. Please don't give up. Just hope is real. And, I do believe we can make a difference here. I do believe people can restore a quality of life that they once enjoyed before COVID. And so I just would say, there's going to be times it's going to be tempting to say, this is it, but don't give up.
Yeah, I mean, I think this conversation underscored how much work remains in the fight for COVID-19 and long COVID recognition, research and support. Public health is at a crossroads that we just can't afford to look away from. And the ongoing rollbacks of protections, the lack of urgency around long COVID, the erosion of public trust makes it clear that we must demand better. We must stay informed, advocate fiercely, and hold leaders accountable. Our voices matter, our lives matter, and we shouldn't be ignored. We are committed to ensuring that long COVID patients are heard, that public health remains a priority, and that meaningful solutions are implemented. We know that advocacy, education, and policy change don't happen in a vacuum, and they require all of us to take action. So we want to thank you for this important discussion. Thank you for being here today, for engaging in this critical conversation, and for your commitment to understanding the ongoing challenges of COVID-19 and long COVID. The road ahead is difficult, but we are not powerless. We are a community, and together we can drive change. And then I just wanted to leave our community and those on this call today with some resources. With this week being Long COVID Awareness Week, we do have our Awareness Week toolkit that you can find on our website, and hopefully we'll be plugging some of those into the chat as we go here for you all. Every day we have a toolkit for that day's actions, and we're sending out emails and social media posts around 9:15 every day. So be sure to check in for that day's actions and participate. We also have our comprehensive guide to long COVID, which is a patient-developed 500+ page resource. The comprehensive guide provides critical information on COVID-19 prevention, testing, treatment, and medical documentation. It explains long COVID's causes, symptoms, associated conditions, and the specialists involved in care, while offering practical guidance for patients on recognizing symptoms, preparing for medical appointments, and accessing support groups and research opportunities. It also addresses self-advocacy strategies, securing accommodations, and combating discrimination in healthcare, workplace, and schools. And it also highlights the role of medical professionals in patient care, and the ongoing needs of the long COVID community, and policy recommendations for government support. We also have the NASM Long COVID Report and Definition, which is very important for clinicians and researchers and policymakers to read and understand and use, guiding their long COVID work. And we also have general resources on our website, and ask that you subscribe to our mailing list, follow and engage with us on our social media channels, and help support our work. As you heard, our challenges are even more than they have been over the last couple of years, and it is an uphill battle and fight. As a patient-led organization, we rely on your support to continue fighting for awareness, research, and policy change. So if you're able, please consider donating. And again, public health isn't just about institutions, it's about all of us. And we want to thank all of you for being here today, and ask you to stay safe, stay informed, and keep fighting. And a last thank you again to Dr. Osterholm for his time and commitment to this field, and joining us today during Long COVID Awareness Week.